Welcome, everyone, to United Services Legislative Info Session. I am Diane Manning, President and CEO. The theme for tonight's presentation and the overall theme we have adopted in 2020 is We Are Essential. Here you see the cover of our 2020 annual report. And tonight, you will hear about the resilience of our staff who have continued to come to work every day of this pandemic. They've adapted and innovated to meet the community need, one that is continuing to grow at an alarming rate during these unprecedented times. And they do this for a shockingly low pay rate. They've worked every day of this pandemic, and they deserve to be rewarded for that. Despite the barriers our staff and we as an agency have faced, we have been here and will continue to be here every day for our clients. Tonight, we take that role one step further in drawing attention to a service system that is severely lacking here in Northeastern Connecticut and advocating for one that can better support our hardworking staff and serve our community. So, who are we? We're a comprehensive nonprofit community behavioral health center, and we operate more than 30 programs under our one administration. That means we can be efficient, effective, and a one-stop shopping for individuals who are in crisis in our communities. And who do we serve? Well, in FY20, we provided over 100,000 units of service to more than 3,000 people here in Northeastern Connecticut. This is a quick snapshot of our numbers. Tonight, we will be largely focusing on calendar year 2020. Because the effects of the pandemic are certainly going to impact us throughout the rest of this year and likely longer. So we are not looking at fiscal year 20, but calendar year 2020. It's important to note, though, that the number of people served and the number of services held steady or increased across our programs last fiscal year. We were told by the state not to see people in person for most of our programs from March to June, so the entire last quarter of the year. We continued to serve them, however. These numbers really are a testament to our rapid deployment of telehealth and our staff's hard work and creativity in finding ways to connect with clients and meet their needs in ways that were safe for both staff and the people we serve. United Services is an integral part of our region's healthcare system, and we work collaboratively with our partners to ensure the best outcomes for our clients. In 2019, Project Notify was launched by the Department of Social Services. When a patient with Husky has an emergency department admission or discharge, or an inpatient admission or discharge at a participating hospital, whether it is for mental health or physical health care, a notification is automatically generated by the hospital. It's then sent to Project Notify, who keeps a database of the outpatient providers for that patient. They then send a secure direct message to us notifying us of the admission or discharge as well as the diagnosis. Project Notify is a program under CONNIE, C-O-N-N-I-E, the Connecticut Information Exchange. CONNIE will allow providers to exchange health information securely and quickly. The rest of CONNIE is not launched. Even their website isn't done yet. So Project Notify is the main product we're using for now. In 2020, medical costs included 1,875 emergency department admissions, 740 unique patients shared with the hospitals that are participating, and 496 of whom went to the emergency department more than once, so 67% of those people, and 323 inpatient admissions. These numbers do not include Day Kimball Hospital, as they do not currently participate in Project Notify. So looking back on 2020, it's a bit scary, but we also have a lot we are proud of from last year. As many of you know, telehealth was previously largely not reimbursable for behavioral health services, particularly for Medicaid in Connecticut. In March, that change was quickly made at the state level, and once that happened, we rapidly deployed an entirely new service delivery system. It's important to note that this occurred almost at the same time we launched our new electronic health record, an upgrade we made using OPM nonprofit grant funding. So in the span of weeks, our staff had to adapt to connecting with clients in an entirely new way using this new telehealth system, and then documenting those services in a new EHR. So right from the start of the pandemic, our staff were really just leaping over mountains to get the job done. So here you can see a screenshot of what our system looks like. Those were two of our child guidance clinicians demonstrating some of the activities they were doing with children over the video sessions. From March to June, we provided more than 11,000 units of service over telehealth. In the end of June, we started a gradual return to in-person services. Of course, all sorts of new safety protocols had to go into place. So here's our main entrance in Dayville. You can see those 6-foot markings and some new glass that we put in to protect both staff and clients. We couldn't get plexiglass dividers anywhere that would work well. So our IT department actually created their own assembly workshop in our Dayville conference room and built dozens of dividers by hand for use throughout our facilities with materials we could source. Here you see the finished product in one of our psychiatrist offices. This is a community bag. Everyone who works out in the community and all of our agency vehicles are equipped with these, so they always have a supply of PPE and cleaning materials with them. This is our Dayville PPE supply just a few weeks ago. We're now in good shape. We are continuing to stock up because our infection control nurse advises us that we will really need it over the next few months. And that's because the crisis is not over. We are seeing much higher stress levels in our clients. We are seeing more substance abuse, and we're seeing a huge increase in people in crisis. From July to December 2020, our crisis response services team averaged a 236% increase in services delivered over the same period in the previous year. This upward trend is continuing, and frankly, there's no end in sight. These clinicians are certainly some of the heroes of this pandemic. They never stopped supporting the community and continued to go out into the community to provide services to individuals all year long. What we haven't fully seen yet, but we will, is a spike in child abuse and neglect cases. Reports to DCF are way down, and it isn't because abuse and neglect isn't happening. Many mandated reporters aren't getting eyes on kids at all, so they aren't seeing anything to report. Outreach to at-risk families has been limited. In times of stress, there is always increased domestic violence and child abuse. We are seeing the domestic violence side of it, and we are trying to prepare for the child abuse side of it to come to light, because we are going to be absolutely flooded when it does. So a few other 2020 highlights. This is our new medical director, Dr. Sarah Diasis. We also launched medication-assisted treatment for alcohol dependence to add to our medication assistance for opioids. Here we see a lot more alcohol abuse than opioid abuse. We were already funded for MAT for opioid abuse, and that program is going well. But to respond to our community, we started MAT for alcohol without any additional state funding. So what's next? The effects of COVID aren't going away anytime soon. And despite all we have accomplished this year, and we do feel really good about that, we are still operating with a bare bones service system out here in the Northeast. We have huge gaps, and we work hard and creatively to bridge those gaps ourselves, but we really need help, and our clients deserve it. Unfortunately, this image of a person standing on the edge of a cliff is a reality for many of our clients who are needing services that just don't exist here. For those of you who have attended these briefings, usually including dinner, in years past, and that is most of you, you know we have been talking about this for years. But we look at it as another type of service to our clients. We owe it to them and to all the people who live in our catchment area to advocate for a service system that can actually meet their needs. So what does that look like? Let's start with what we have here in northeastern Connecticut. Unfortunately, this cycle is all too common out here. We start with someone in crisis. They head to or are taken to the emergency department. They need an evaluation or perhaps a medication adjustment, and they are volatile, but they aren't in imminent danger, so they're sent home where they continue to struggle. They're told to make an appointment for outpatient treatment, and we will see them quickly. However, an hour or two of therapy in a week is often not enough when you are in crisis. Before too long, they're getting scared or overwhelmed by their anxiety and depression. Their medications haven't stabilized yet, and they don't have any support at night or on weekends. They end up in crisis again and are back in the ED. Here's how things could look better. So we started out in that same way in crisis at the ED, discharged after medication adjustment that hasn't fully taken effect yet. But instead of going home with no support system, they are able to stay in a respite program. They have support on site as they learn to manage their new medications, and someone is available day or night when they are struggling. For most people, staying here for a week or 10 days would make a huge difference. They will be more adjusted when they get home and able to work toward recovery with the outpatient support we have available here. There's one more type of client I'd like to talk about. We have people with a high acuity of need, and they are constantly struggling with stability, and from some diagnoses, that is the reality of their mental illness. Our community support program provides 1 hour of case management services per week, and it is a skill-building program. It is designed for people who are stable and in recovery, and to keep them well and living on their own in the community. For these people with intense needs, this simply isn't enough, and this is a population that struggles to engage in the outpatient model as well. It's important to note that this is the population that interacts with the police and the emergency departments all the time. Their behavior is disruptive to the community, and they are frequently stuck in that cycle of crisis, and there is nowhere to go that works for them. What this population needs is enhanced mobile treatment and support, including 24/7 supervised housing, where they can receive clinical and intensive case management supports within their homes, where they will actually engage with the service and get closer to functioning and recovery. So what can you do? You can support existing services that have been underfunded for years, including staff providing critical services. You can require a plan from the Department of Mental Health and Addiction Services for access to the same set of community services in the northeast part of the state as other parts of the state, and a plan for how this can be achieved. The Police Accountability Bill needs a little bit of work to clarify what is needed to support collaboration with mobile crisis services. This has been an area we've been struggling in over the last few months. So thank you, as always, for listening and supporting United Services. We'll switch from the PowerPoint presentation and open up for questions and comments. Thank you.